But I figured it's probably time we wrap all of this up. So I'm going to try to get through all the material that I wasn't getting to on previous talks, and then we can pick up with something different. So aerosol therapy, new drugs, new devices, of which there are a lot. When I started putting this together months ago, I was impressed with how much new stuff was out there that I thought I knew, which I didn't. So we're going to try to wrap up this nebulous topic, like my pun. So the objectives are to compare nebulizers, pressurized meter dose inhalers, soft mist inhalers, and dry powder inhalers, to discuss important factors in the selection of a specific aerosol delivery device for an individual patient. So we'll try to buzz through this fairly quickly. In previous talks, we talked about nebulizers and pressurized meter dose inhalers, soft mist inhalers, so we'll kind of buzz through that as a review. We had not talked about dry powder inhalers, so we'll talk about those in more detail. And then I want to spend a fair amount of time talking about how we should go about selecting a specific device for an individual patient. And then we will talk a little bit about the cost of some of these drugs and devices. You may be surprised, as I was surprised when I put up on the slide how much some of these drugs cost, and that some of them, which are COPD drugs for patients on Medicare doesn't cover. So that is a big problem for our patients. So we wonder why our patients don't take our drugs. Well, that's part of the reason. And then we'll touch on the GOLD for COPD and GINA for asthma guidelines and what their recommendations are for the use of various drugs specifically. So aerosol generators then are primarily of four types. The nebulizers, which can be jet nebulizers, that's the traditional nebulizer, or ultrasonic nebulizers or mesh nebulizers. There is the Respimat soft mist inhaler, which has only been available for a little bit over 10 years, and we'll talk a bit about that. There are now a number of drugs that are available for that device. Talk a little bit about pressurized meter dose inhalers. We covered that in some detail the last time around, so I won't get into as much detail this time. We'll address the question, does everybody need a valve holding chamber or spacer? So we'll get to that in a few minutes. And dry powder inhalers, of which there are now a number of formulations available as dry powders. So shown on this slide are some examples of jet nebulizers, ultrasonic nebulizers, and mesh nebulizers. For each of these, there are devices that are designed to work off of wall, air, or oxygen, or there are portable devices. So later on in the presentation, we'll come back to this device. This is a portable jet nebulizer compressor combination. It's relatively small, it's battery operated, it's portable, it's easy for patients to take with them. There are some expensive types of nebulizers that are designed to be more efficient and deliver more drug to the patient. I'm not going to get into that. We talked about those in detail the last time. There are a number of portable ultrasonic nebulizers that patients can use at home. Some of these are device specific. So this is the Optineb, which is used specifically to deliver treprostinil by inhalation, which is a pulmonary hypertension drug. One of the things that's important, told me there are problems with my Apple Watch, problems on the blue line, and there are problems with the Uber. So one of the issues with the ultrasonic device is that not all drugs are compatible. We'll come back to that point in a few minutes. So there are a lot of drugs you can put in the jet nebulizer. Some of them cannot be used with the ultrasonic nebulizer. And then there's the mesh nebulizer that you know from putting it in line in the ventilator circuit. That can also be used by patients at home with this spacer device, which is called the Ultra. So not only can the mesh nebulizer be used in the ventilator, it can be used for spontaneously breathing patients. And another type of mesh nebulizer, the eFlow, is now being paired with a number of new drugs that are coming onto the market. So the direction that Aerogen took was put any drug in here. The direction that PARI and the eFlow folks took was to work with drug companies so that their device works with specific drugs. And here are some examples. So Strianam, which is an antibiotic used as an alternative to tobramycin in patients with cystic fibrosis, is used specifically with the Altera nebulizer and the PARI eFlow base device. So the mesh nebulizer in this device has been built specifically to optimize the delivery of a Strianam. And we should not take a Strianam and dump it into a jet nebulizer or an ultrasonic nebulizer, because it was formulated specifically to be used with this device. Another example is amikacin liposome inhalation suspension. Again, same basic device. So the same basic device, but now the mesh nebulizer is built specifically for this drug, which is used to treat MAC infection, again, primarily in patients with cystic fibrosis. So a patient with CF then might have this device to deliver their inhaled Strianam and this device to deliver inhaled amikacin.
So how much real difference is there between the two?
So the difference is the base unit is the same. The difference is in the mesh, which has been built specifically to deliver
different
that
densities,
drug.
etc.
You're right, to deal with different drugs, densities, viscosities, and so forth. And then the newest device that uses the PARI eFlow base device is the Magnar, which delivers inhaled glycopyrrolate, which is a long-acting muscarinic antagonist, an anticholinergic. With this device, there is a vial which contains 1 milliliter of drug, snaps into the device, and then again it is a mesh nebulizer powered with an E-base. And this device, by the way, can either be is electrically powered either with batteries or you can plug it into the wall. So you can begin to see how this might be very confusing for patients who have multiple drugs that are prescribed with kind of the same device but different. Now, there have also been, well, at least one drug that's come out just within the last 6 months, which is not designed to be used with any specific nebulizer. This is a once daily, long-acting muscarinic antagonist. This can be used with any jet nebulizer. So one of the issues with devices like this is that they are very expensive. With this device, you can use it with an inexpensive jet nebulizer, but you know what the rub is? The drug is very expensive, as we'll see a few slides down the road. So they kind of get you either way. Also on this slide, I have boxed jet nebulizer. If you look at the package insert, it specifically says that it has to be used with a jet nebulizer, cannot be used with an ultrasonic nebulizer, cannot be used with a mesh nebulizer. And as you know, and some of you who were at some of the previous talks, I've shown this slide before, now there are a number of nebulizer drug combinations so that some drugs are only FDA cleared devices, and in some cases it's impossible to use the drug other than with the device that it comes with, a Strianam, for example. First time I showed this slide, Bob pointed out that I needed to take off ribavirin, so I did.
We threw away the ribavirin.
Yeah, it turns out that the company doesn't even make them there. You can't even buy them anymore.
So great. That's great.
Okay, so another device that I want to spend a few minutes talking about is the Respimat Soft Mist Inhaler. This is a device that came onto the market probably more than 10 years ago, but not more than 15 years ago, probably in the last 10 to 15 years. This came onto the market as an alternative to metered dose inhalers, when metered dose inhalers changed the propellant from fluorocarbon, Freon, to hydrofluoroalkane, HFA. So what some companies did was, rather than to reformulate their metered dose inhalers, they came up with new devices. And this is the device that Boehringer came up with. Now there are, in the United States, this one's only available in Europe. In the United States, there are 4 different formulations that are available with this device. So they include combination drugs, short-acting muscarinic antagonist and beta agonist, long-acting muscarinic antagonist and beta agonist, a long-acting beta agonist, and a long-acting muscarinic antagonist. So there are a variety of drugs now that are available by this device. It produces a very soft mist. There's no propellant, no compressor. So no compressor like we would need with a jet nebulizer, no propellant like with a metered dose inhaler. And it's relatively simple to use. So what delivers the drug, pushes the drug out of this device, is a spring. So there's a spring that surrounds a collapsible bag. The collapsible bag contains the medication. How you use it is you turn the base. When you turn the base, that compresses the spring. That puts pressure on the bag. And then when you press the button, it releases the medication out of the mouthpiece. So relatively simple, I think, for patients to use. Turn the base, put it in your mouth, begin to inhale. At the beginning of inhalation, press the button, inhale to total lung capacity.
So the aerosol is simply the result of pushing the solution through a small orifice.
Correct. Right. Yeah. So the other thing I should have pointed out here is so here we have the drug and the cartridge, and then up here in the dosing chamber and the unibody is where it determines the dose that is delivered and aerosolizes the dose. There are actually a whole bunch of little fine holes that pushes it through.
So this is, you have to buy the full device. When the
Correct.
device is empty, I got to buy another device.
Correct. So
not a drug filler, but another device.
Correct. So typically in this device there's 1 month's worth of medication. And there is also, I didn't put a picture on the slide to show, but there is a dose counter. So you can keep track of the dosage. So it gets thrown away as a metered dose inhaler would.
Right.
By the way, where this device really got some traction is with CombiVent, because CombiVent was available by metered dose inhaler, and the company took CombiVent off the market, the metered dose inhaler, and brought this on the market to replace it. So 10 years ago, anybody who was prescribed CombiVent went from using a metered dose inhaler to using the Respimat device. So a few words about metered dose inhalers. So only about 10 to 20% of what comes out of the mouthpiece actually gets deposited in the lungs, assuming that the patient has good technique. Where does the rest go? Your mouth and pharynx. So that's a problem because you swallow the drugs, you get thrush infections and so forth. And that's the reason to use a spacer or a valve holding chamber. And certainly the deposition goes down if the patient doesn't use good technique, if the patient's blowing out through the mouthpiece when they're actuating the device, the amount that gets deposited is 0. One of the issues with metered dose inhalers over the last 15 years is that they were extremely expensive. So when we had the Freon-propelled metered dose inhalers, there were generics for almost all of the drugs. And albuterol inhalers were very inexpensive. When the HFA formulations came out, some of these inhalers cost hundreds of dollars. I don't know if any of you had any experience with that, or yourself or your family, but it became a real problem for some people because their copays went from like $5 to $50 for their albuterol. The good news is that generic albuterol has been recently cleared by the FDA, and it is out there now. You can get it, and it is half or less of the cost than the HFA formulations of albuterol from just a year ago. One of the things that many patients do not know, and this is something that is important, I think, for us to teach our patients, is that if the device is new, if the meter dose inhaler is new, or if it has not been used for some time, and you can see some of the dates here, some of them up to 10 days, some of them up to 2 weeks, some of them for as little as 3 days. So if the device is new or has not been recently used, it needs to be primed. So what that means is you shake it, you discharge it into the room, you shake it, you discharge it into the room. So for example, albuterol, HFA, Provent, Ventolin needs 4 wasted actuations before it is used in order to prime the dosing chamber. And it varies a bit from device to device. But I think as a general rule, 3 or 4 actuations from the device if it's new, or if it hasn't been used for some days, such as a quick relief medication that the patient may use infrequently. Question I've been asked already, giving talks similar to this, is, well, does the company consider that when they fill the device? And the answer is no. So typically, the device for use at home is 200 actuations. So if you only end up using the device a couple of times a month, you might end up wasting as many actuations as you actually use. The other issue is for patients to know when their device is empty and it needs to be replaced. And fortunately now, I believe that almost all the devices have a counter. The FDA now requires that any new formulations of meter dose inhalers coming onto the market have a counter. There are add-on devices like this doser device that you can add if the meter dose inhaler does not have a counter. I don't know how many of them they ever ended up selling because it adds expense to the patient, and it is not, I don't think that insurance companies and Medicare typically cover. So then 2 important issues. So I think when we teach patients, we talk about things like the importance of shaking it and the importance of actuating it at the beginning of ventilation, those kinds of things. But I think it's equally important that we talk to patients about the issue of priming. Probably not an issue if their meter dose inhaler is a steroid that they take every day, but could be an issue for their quick relief medications. And then being certain that they do not use the device after the labeled number of actuations. There are studies in the literature of patients coming to the emergency department with acute asthma, and they've been using an empty inhaler for the last days. Now, a drug that has just recently come onto the market, I think just within the last couple of months, is the breath-actuated QVAR Ready Haler. I want to say Ready Inhaler, but it's Ready Haler Inhaler, I guess. And this is a breath-actuated device, so that gets around some of the issues with hand-breath coordination. As the patient puts it in their mouth, they begin to inhale. The patient breathing through the device actuates the device to deliver the drug. So that it's breath actuated is perhaps an advantage. It should not be shaken or primed. That's an advantage as well, particularly the priming part. And also, I think most patients probably remember to shake it, but maybe not. But this one does not need to be shaken or primed. And this one cannot be used with a spacer or a valve holding chamber because with a spacer or valve holding chamber, you don't get the flow through the device that you need to actuate it from the patient's inhalation. This could be a problem because the drug is a steroid, beclomethasone, Q-bar. So without the use of a spacer or a valve holding chamber, it increases the amount of drug that's deposited into the upper airway. So with this device, it's extremely important that patients know that they need to rinse out their mouth and upper airway after they use the device. It does have a dose counter, as you can see. So this addresses, I think, some of the issues with meter dose inhalers, but it may introduce some other issues as well. I don't know how much traction this is getting in the marketplace. It's only been available for a few months. So, a few words about spacers and valve holding chambers. So some of these devices are tube spacers without any valves. The problem with a device that doesn't have valves is that the patient can blow through it and waste the drug. So this device doesn't help very much the hand-breath coordination. But what it does help is with the spacer, it decreases the amount of oropharyngeal deposition of drug. So the spacer then ends up taking much of that drug that would go into the oropharynx and trapping it into the tube spacer. There are reverse flow devices where the aerosol sort of goes backwards into a chamber or into a bag, and then the patient inhales it. I'm not sure how popular these devices are. I think the most popular devices of this class are the valve holding chambers, where there are valves, so that by incorporating a valve, it improves hand-breath coordination because the patient can't blow through it to waste the drug. And then it also serves as a holding chamber so that drug that otherwise would be deposited into the oropharynx gets deposited into the device. And the last time I was here, we talked about these devices in more detail. I'm not going to do that today. So I think an important question is whether every patient needs a valve holding chamber. So does every patient need to have a valve holding chamber? And I think it depends. So for a quick relief medication, albuterol, if the patient has good technique with the use of the device by itself, there's not much that is gained by adding a valve holding chamber. And the reality is that a lot of patients won't carry that around with them through their daily activities anyway. They'll carry around the meter dose inhaler, but they won't carry around this valve holding chamber as well. However, for inhaled corticosteroids, a valve holding chamber is imparted, and I think every patient who uses inhaled corticosteroids from a meter dose inhaler should use that with a valve holding chamber to reduce oropharyngeal deposition, thrush in the upper airway, and to avoid swallowing of the drug and systemic effects. And the valve holding chamber does add some cost for the patient, and we'll see what the cost is a few slides down the road. So I think my read of the literature supports this slide, and that is for albuterol, patient has good technique, don't need a valve holding chamber. Patient can take their meter dose inhaler with them, leave their valve holding chamber at home. For their inhaled corticosteroids, use a valve holding chamber. Whoops. Thought the power went out.
Yes, it is.
I was giving a lecture in Mexico City a couple of years ago, and I was in front of the group. I was lecturing. I was looking at the laptop where my slides were, and then people started pointing like this, and the power had gone out, so my slides weren't projecting, but I could still see them on the battery-powered laptop. Okay, so then, valve holding chamber. So for inhaled steroids, the patient typically uses it once or twice a day, so they can still use the valve holding chamber at home without having to take it with them everywhere they go. Okay, dry powder inhalers. So far, we've had a bit of a recap of what I've talked about in some previous lectures. We haven't said very much about dry powder inhalers yet. There has been a proliferation of these devices that have come onto the market just in the last 10 to 15 years. Way back long ago, probably Bob and Purvis and Ed are the only ones who remember the rotohaler with chromo. That Dave remembers too. That was available for probably through the 80s and maybe into the 90s. It was the only one that was available for many years. And now there are a number of drugs that are available by dry powder inhaler. And these devices, and this isn't even a picture of all of them, but these devices I think we can group into devices that are multiple dose devices. Typically the multiple dose devices contain 1 month's worth of medication. So the patient uses it for a month, like the Respimat, throw it away, go to the drugstore, they get a new one. Or the devices can be single dose devices where a capsule needs to be put into the device and the capsule punctured with each use. So this then, the single dose devices, I think are going to be more difficult for patients to use typically than the multiple dose devices. And for the single dose devices, it's important for the patient to be instructed not to eat the capsules. Because the capsules, the Spiriva capsule for example, doesn't look that much different than the pills that patients might take for their hypertension and for other problems that they have. So it's tempting for the patient to say, the heck with this thing, put the capsule in, you have to break the capsule and breathe strongly through it, I'll just take it with my other medicines. The good news is, if your patient does that, it doesn't hurt them. The bad news is, it doesn't help them either. So there's a reason why these drugs were designed for inhalation. One family of inhalers that has become very popular over the last couple of years are the Ellipta dry powder inhalers. And these are available now in a variety of formulations. They are available as single drugs, like long-acting muscarinic antagonists, inhaled corticosteroids. They are available in combos as duo drugs, inhaled corticosteroid, long-acting beta agonist, or long-acting muscarinic antagonist, long-acting beta agonist. So this would be an asthma drug with the focus on the inhaled corticosteroid. This is a COPD drug with the focus on the long-acting muscarinic antagonist. More about that towards the end of the presentation. And the newest combo that's been available now for probably 2 years or so contains an inhaled corticosteroid, a long-acting muscarinic antagonist, an anticholinergic, long-acting beta agonist. This is a COPD drug. And the advantage of the combos, by the way, is that the patient gets all their medicines on one inhalation. So that is a lot more convenient than needing to load up the nebulizer with several drugs or to reload the nebulizer because drugs aren't compatible and so forth. And another powder, dry powder, is the Toby Podhaler. So this is an alternative to Toby by nebulizer, Toby by dry powder inhaler. You probably maybe didn't even know that this is an option for patients with cystic fibrosis. It's not widely used because it is a bear to use. So patients need to take multiple capsules, needs to get reloaded multiple times with each treatment. It is not nearly as convenient to use as the Toby solution and the jet nebulizer. So a few things about the technique for dry powder inhalers, and I bolded the important things here. So one of the confusing things, at least for me, maybe you can remember all this, but at least the confusing thing for me is these devices all have different ways of prepping the device, the dose. So with the elliptic device, you sort of open it and it's ready to go. With the discus device, you have to push the handle on the side. With the flex hailer and the twist hailer, you have to turn the base. For one of them, you turn the base before you inhale. The other one, you turn the base after you inhale. The, the single dose devices, you have to put the capsule in each time and puncture the capsule before you use it. So there is no uniform way in which the dose is prepared for these various devices. So imagine that you're a patient with COPD and you're 75 years old, and you have a meter dose inhaler and you have two different dry powder inhalers. How confusing would that be in order to keep all of that straight? The other thing is, with the dry powder inhalers, the patient needs to inhale forcibly. Whereas, what do we tell our patients who use a meter dose inhaler? Inhale slowly. So imagine a patient who uses a meter dose inhaler and a dry powder inhaler. The confusion now is this one. Do I breathe in slow with this one? Do I breathe in fast? Do I shake this one or don't I shake this one? It'd be very confusing for patients. And then the importance of rinsing the pharynx after each dose in order to reduce the amount of swallowed drug and to reduce the risk of thrush candidiasis in the upper airway. And that's what I point out on this slide. So with an inhaled corticosteroid, there can be a lot of drug that deposits in the upper airway. That can result in thrush infections in the upper airway. It can also result in swallowing of the drug, and that can result in systemic side effects for the patient. So we get around this issue by using a spacer and valve holding chamber with a meter dose inhaler, provided it's not the Q-bar meter dose inhaler, and for any of these devices to rinse the upper airway after the drug is used. There are also powders that are now available for inhalation that are not designed to treat lung disease, but are specifically designed to be absorbed from the lungs into the circulation to treat systemic disease. So this is the Alfresa device. Looks big here, doesn't look quite as big here, which is used to deliver inhaled insulin. So it's used for the treatment of patients with diabetes. And this one, which only became available in the last several months, which is inhaled levodopa, which is used in patients with Parkinson's disease. So the patients on their regular medicine for Parkinson's, their levodopa, which is not inhaled. But typically what happens is that symptoms will begin to return before it's time for the next dose, or it's time for the next pill. So then patients will use the inhaled levodopa in order to get them through that off episode before they take their next oral medication. So I think we're going to begin to see more and more drugs that come out by inhalation that aren't designed specifically to treat the lungs. The lungs is just a way of getting the drug into the system. And in the case of inhaled insulin, doing that without the use of a needle. So one of the things that can be confusing for patients is with the device that they're prescribed, how fast should they breathe in? So dry powder inhaler, they need to breathe in fast. Meter dose inhaler, they need to breathe in slow. And moreover, these various devices have different inhaled resistances. So for a high resistance device, you have to pull in really hard to get the high flow. For the low resistance device, you have to pull in as hard in order to get the flow for a dry powder inhaler, for example. So this device, which is called the in-check device, is used as a trainer device for patients, and the device can be adjusted for the resistance of the device that the patient is being trained for. There is an inspiratory flow indicator on the device, and then the patient can use this to learn how to use their device correctly. In other words, you can set this up to simulate, for example, an elliptic device, and the patient uses this to learn the inspiratory flow characteristics to use that device. Or you can set it for a meter dose inhaler and so forth. And I think you have some of these here now.
Carla's got some.
Carla has some? Okay.
They have one.
I don't think they're in use in inpatients. I think it's only for outpatients. So.
Well, the intent would be to have a patient learn how to use their device correctly
Yeah,
at home.
she teaches them here,
yeah.
and then they go home with it. But it's
Yeah.
not, they're not routinely ordered.
Yeah, this device is getting some attention in the peer-reviewed literature. There are a couple studies out now about describing the benefits of the device and so forth. So now we have all of these different drugs and all of these different devices.
And everybody
And
knows all of those, right?
And this is an old slide. So it doesn't even have some of the newer things that are on here. So then, how do we decide what is the best device and what is the best device-drug combination for an individual patient? So what are the things that we need to consider when selecting an aerosol delivery device? These are some clinical practice guidelines that were published in CHEST back in 2005. And I was part of the writing committee for these guidelines. And essentially, the charge to us was to determine which device is best. So, is a nebulizer better than an inhaler? Is better than a dry powder inhaler? So that's what we were supposed to, that's the question we were supposed to ask. And then we were supposed to answer that question. That was the question that was asked. We were supposed to answer that question, what about a patient in the emergency department, in the ICU, at home, and so forth. So we spent a couple of years, reviewed all of the world's literature, and which device is the best. And a patient who can use the device correctly, it doesn't make any difference. So they're all the same if the patient can use the device correctly. Now, you know, not every patient can use every device correctly, but probably for all of us in this room, we could use any of the devices correctly and get the benefit. So then as a group, we said, well, you know, if we publish a paper, we say we did all of this work for the last 2 years, and what we concluded was all the devices are okay to use. It's not going to help anybody. So we came up with a list of questions that individual clinicians should ask about individual patients in order to determine the best device for a patient. So these are the questions that we come up with. So in what device is the desired drug available? If the drug is Toby, rules out meter dose inhaler, right? Could be a dry powder inhaler, could be a nebulizer, not going to be a meter dose inhaler. What device can the patient use properly? So all the devices are equally effective if the patient can use them properly, but all of us know that patients can't use every device properly. So which one can the patient use properly? For which device is reimbursement available? Because these drugs are expensive, as we're going to see on the next slide. So which one does the patient's insurance cover? Which one does Medicare cover? Which one does Medicaid cover? And if the device is expensive, so which is the least expensive, and is there a generic? Because if there's a generic, that will be a less costly alternative. And then can all of the types of prescribed inhaled drugs be delivered with the same type of a device? So when we look at the drugs that the patient needs, can we find a device that uses all of those different kinds of drugs so the patient doesn't get confused about how do I use my meter dose inhaler, how do I use my dry powder inhaler, and so forth. So let's look at this for a little bit. So it turns out that only the jet nebulizer can be used for all drugs. So the jet nebulizer is the only device for which all the drugs are available in a solution and can be used. And I'm not talking about the esoteric things like insulin and levodopa and so forth, but for respiratory disease. So this nebulizer, which I showed you a picture of earlier, relatively small device, battery-powered jet nebulizer, that's the PARI device, and you can buy that for about 65 bucks. By the way, if you're interested in how much drugs cost, this is a very useful website, drugrx.com. It has every drug there, and it tells you, gives you a list of how much does it cost at CVS, Walgreens, Walmart, and so forth. So that's, actually that's an exercise that I have my graduate students go through in one of my courses, because it's very eye-opening when you see how much these things cost for patients.
I think the other thing that people don't realize is many of these companies, if you are not on Medicare or Medicaid or federally funded, there are ways of getting the drug costs reduced enormously.
Yeah, you can get coupons essentially.
Yeah, I mean, I have 2 drugs that I take that I pay nothing.
Yeah.
You know, they'd be like they're 100 or 150 bucks a month, and I pay nothing for them.
Yeah. So then
if I was on Medicaid, I'd have to pay.
Yeah. So out-of-pocket cost is determined by your insurance and your Medicare coverage, and then whether there are any of these kinds of deals that you
But there are
get.
a lot more of those deals available than I think people realize.
Yeah.
I would always look into it. If you have an expensive drug you got to take, is look into the company literature, and a lot of times to talk to the pharmacist, you can find that there are options.
Yeah, so look at how expensive some of these are. So for a long-acting beta agonist, or for Motorola, Brovana, to go into a jet nebulizer, $1,000 for 60 vials. So if you bought the, so if you use the PARI, eFlow, Lunhala, Magnar device, that's expensive. But it's also expensive to use the cheap nebulizer and buy the drug. And also notice that some of these drugs are not covered by Medicare. So the other thing you can find out on the GoodRx website is whether the drug is covered by Medicare. So it can be, depending upon your insurance, depending upon the amount of Medicare coverage, depending upon whether you have vouchers or not, it can be really expensive for patients to use these drugs. And many of these patients don't just have COPD or asthma. So patients with COPD, they have cardiovascular disease, they have adult onset diabetes, they have other issues as well. And the cost of drugs can be, outrageous is the right word. The cost of the drugs can be outrageous, and it is a big determinant of whether or not our patients take the drugs the way they're supposed to when they go home. So we see them, we explain to them how to use their various devices, what the drugs are, they go home with their prescription with every good intention till they show up at CVS. And then they decide, well, maybe I won't use that long-acting muscarinic after all. The doctor said it's a good new drug, but I can't afford it. So then, what are some of the non-nebulizer approaches? So let's say we want to mix and match. So the drugs, actually as it turns out, the drugs are a bit cheaper on this slide than they were on the previous slide, and all of the drugs on this slide are covered by Medicare. So that doesn't mean the patient gets them for free, but it means that they don't have to pay the whole thing out of pocket. Another thing to consider is the amount that the patient has to pay out of pocket depends upon the tier of the drug. So Medicare and Medicare Advantage plans will place drugs into different tiers. So if the drug is a generic, so albuterol now is available as a generic, the out-of-pocket cost for the patient is probably not more than about $10. Whereas if it is a specialty drug, the patient can pay a lot out of pocket, And then the other issue is that you might have heard of is the Medicare donut hole. So that means that the drugs are covered with these copays up until $3,820. So that's the total cost of the drug, not the out-of-pocket cost for the patient, the total amount of cost for the drug. When you get to $3,820 up to $5,100 for a individual calendar year, then Medicare will pay 25% for brand names and 37% for generics. Bottom line is, if you go into the donut hole and you're on Medicare, the cost of your drugs goes up a lot. And if you are using an expensive drug that costs $1,000 a month, it only takes a few months till you are in the donut hole. And then for a couple of months you're on your own. Well, you're on your own for a lot more cost till you get up to $5,100.
Does supplemental insurance pick any of that?
It depends upon the insurance that you
You
buy.
have, yeah.
So you can buy Medicare supplemental insurance that will get rid of the donut hole, but you pay a lot of money for that. So for somebody who will be going on Medicare, so you have to figure out how much you think your drug costs are going to be per year, and then that will determine the Medicare Advantage or supplemental plan that you might buy. And I wouldn't say that I'm an expert on that, but I learned a lot more about it over the last couple of years. And fortunately for me, many of the drugs that I use fall into Tier 6. So the antihypertensives and the cholesterol-lowering drugs and so forth are zero copay. So I haven't had to worry about the donut hole, but time might come. So some other considerations when selecting an aerosol delivery device. So which device is most convenient for the patient or the family or hospital staff? So generally, patients and hospital staff don't like to use delivery devices that take a long time to deliver the drug. They like something that you can use in a few minutes. Does the patient or the clinician have a specific device preference? So it's hard for us to keep up to date on all these devices as well. So to the extent that we can narrow what we need to remember will affect our preferences. Proper patient education is critical. That is an important role for us as respiratory therapists. There are at least 3 studies that were done now about 20 years ago looking at how well respiratory therapists versus nurses versus physicians versus pharmacists taught patients how to use inhalers. And every study showed that respiratory therapists do a better job than other clinical people because that's what we do. That's part of our training. Physicians are never taught any of this stuff in medical school. Nurses aren't taught any of this stuff in nursing school. Pharmacists probably are, but this is a small part of what they do. And then finally, physicians, respiratory therapists, nurses, and I should also say pharmacists caring for patients with respiratory disease should be familiar with correct device technique. And this was a lot easier 15 years ago when we only had a few devices than it is today. So then, there are a whole lot of inhaled drugs that currently are available, and I think this is the 3rd or the 4th time I've come in and lectured on this topic, and at some point or other, I think we've touched on all of these now. So I wanted to just take a minute to talk about drug preferences according to the GINA guidelines for asthma. And then on the next slide, the GOLD guidelines for COPD. So everything that you need to know about the care of patients with asthma can be found in the GINA guidelines. And this is a figure from the GINA guidelines showing the recommendations for drugs at different steps in the disease, or in other words, with different steps in the severity of the disease. And to sum up everything that is on this slide, what is recommended for relief is the short-acting beta agonist. So as needed, short-acting beta agonists fall all the way along the spectrum. That's albuterol. For the controller medication, what is recommended is a combination inhaled corticosteroid, long-acting beta agonist. So that is the Advair that is commonly used in the management of asthma. And then what is recommended for patients with most severe disease is to consider adding tiotropium, long-acting muscarinic antagonist, that is Spiriva. This is relatively newly added to the management of asthma. So for many years now, it was recommended SABA for release, inhaled corticosteroid, LABA for control, and then the Spiriva was added just within the last several years. So shown here are the recommendations for drugs in patients patients with COPD according to the GOLD guidelines. So everything you need to know about the management of COPD is in the GOLD guidelines. I was actually thinking about doing that as my next series of lectures, is COPD management according to the GOLD guidelines. So here is a figure. This is not me. This is another Hess. This is Michael Hess. So, but I should probably put his first name on there so that I don't take credit for somebody else's work. But he put together this figure, I think, very nicely from the GOLD guidelines. And the bottom line here is that for quick relief for COPD, one should consider a short-acting muscarinic antagonist. So that would be Atrovent, right? And or a short-acting beta agonist. So Atrovent or albuterol or a combo of the two, Combivent or Duonev. And then for control, the initial focus is not on the use of inhaled corticosteroids, but on the use of long-acting muscarinic antagonists. So notice the importance of long-acting muscarinic antagonists in the management of asthma that you do not see in the management of COPD. And combos of long-acting muscarinic antagonists, long-acting beta agonists, and perhaps also the use of inhaled corticosteroids. So this is triple therapy. So if you hear the term triple therapy for COPD, that means a combo of a long-acting muscarinic, long-acting beta agonist, inhaled corticosteroid. So then, let me go here, back here. So then for asthma, the focus is on inhaled corticosteroids and long-acting beta agonists. For COPD, short-acting muscarinic antagonist, long-acting muscarinic antagonist. Okay, so then in summary, there are a variety of aerosol delivery devices that are available, nebulizers, nebulizers, soft mist inhalers, pressurized metered dose inhalers, dry powder inhalers. Consideration should be given to matching the device, the medication, and the patient need. So I think we, as respiratory therapists, are positioned sometimes to make recommendations to our physician colleagues that perhaps putting the patient on Atrovent who has asthma is not the best drug choice. And the patient who has COPD probably should be on a short-acting and a long-acting antimuscarinic. And then finding the device that is the appropriate device to deliver that. It's important that the patient is properly instructed in the use of the prescribed inhalers. Important role for us. In fact, that's my sort of go-home, take-home message. As you do not go home, as I will, but you go back out to your assignment. Is that all of this, I think, is a very important role for respiratory therapists. I think that the healthcare community expects that we will be the experts on this information.